Welcome, welcome everyone. We are beyond excited. My name is Aurora Archer. I am the CEO and co-founder of the Bellatrix Group, a marketing consulting firm focused on solving sticky problems at the intersection of health, technology, and people. Today marks the third of our webinar series in our health and human connectedness. So we're delighted to have all of you here. As Pamela said, we'd love for you to stay on mute unless you are asking a question or would like to raise your hand to ask a question. Please feel free to consistently and constantly use the chat box. We'll be monitoring that and bringing some of those questions to our panelists as we go throughout our conversation today. And without further ado, I'm going to hand over to my partner and co-founder, Pamela.
Hi, everyone. I'm Pamela Raitt. I am a co-founder and the Chief Strategy Officer of Bellatrix Group. I want to echo Aurora's comments. We're really excited and happy to see so many familiar and unfamiliar faces this afternoon to have a conversation that is very near and dear to Aurora and my hearts, which is to talk about women's health. And to talk about women's health from our perspective, which is that it is the ultimate connector. And what do we mean by that? Women's health, the health of women, has been proven to impact the health of our entire society. Healthier women raise healthier children. They contribute to healthier households and healthier communities. And so, you know, Aurora and I and our fabulous panelists are extremely committed to helping find innovative ways to better connect women to the services that they need to be healthy and well. And so we're really excited to have some of our favorite leaders in the healthcare space. We're also excited to bring you 5 panelists who have very different perspectives. Not that they don't all believe that women's health is important, but they are all working at it and coming at it from very different areas and roles within health. And so I will let them I'll turn it over to them to let them tell you what they're doing. And I'm going to first kick it off to my friend Marianne to get us started.
Well, thank you, Pamela, and good afternoon, everyone on the line. It is such a pleasure to be part of this esteemed panel. My name is Marianne Frey, and I'm the Chief Executive Officer for Maternity Care Coalition, which is a nonprofit organization that serves families, pregnant women and their children ages 0 to 3 in the Philadelphia area. And the reason why I think that Pam and Aurora reached out to me is that I guess it is Bellatrix Group sits in the intersection, as Aurora said, of kind of technology and innovation. Well, NCC really sits at the place of transforming communities one family at a time. We are here to help pregnant women that are in need to be able to be empowered to make a difference in their own communities and through healthy outcomes. And you'll learn throughout this session about some of the negative health outcomes which happen in communities of color, which is where we primarily serve. But I'm delighted to be part of this panel and to not only share my experiences, but to learn from each one of you. So I thank you for this opportunity and I look forward to the dialogue. Pam?
Fabulous. Veraj, you want to introduce yourself?
Sure. Thank you, both Aurora and Pamela, for hosting this important discussion. I'm Veraj Parikh, the Chief Experience Officer and co-founder of MOL, which is a company focused on providing an easy-to-access virtual platform to support the mental well-being of all expecting and new mothers as they navigate motherhood. My prior to my role at MOL was as the education director at Hatch Motherhood, and before that I was a practicing women's health PA for 15 years. I have always been mission-driven and focused on the health and well-being of women. And so I'm very humbled to have this opportunity to speak alongside all four of you very accomplished thought leaders. And thank you so much for having me as a part of this conversation.
Thank you, Veraj. We're thrilled to have you, and you as well, Marianne. And I'm going to next ask Roddy to introduce yourself.
Hi, I'm Radhi Cacarla. I am a practicing OBGYN. I've been practicing for 25 years on the main line. And I was also the founder of Hatch Motherhood. Veraj and I worked together. It's changed a lot for me over the years. I think I started off as a physician, going through residency, kind of doing what I was taught, and actually went through kind of a personal evolution, which translated into a professional evolution. And that is what prompted me to start Hatch Motherhood. And it was more about like, how do we start off with wellness instead of fixing people that got sick. So we developed a multidisciplinary approach that focused on mental well-being, physical well-being, and community and connection. And I got to say, for all the stuff that I have done, that was the most exciting years. Those were the most exciting years of my life.
Thank you.
You're welcome.
Thanks, Roddy. We're happy to have you. I'm going to turn it over next to our friend Renee.
Hi, everybody. This should be a lot of fun. We have a lot of diverse backgrounds here. So I approached from a little bit different angle. I spent 20 years at Johnson & Johnson, and I spent quite a lot of time in women's health categories, both on the pharma side and the med device side. And then I just, as my career went on and I changed positions and went into private equity, I still was passionate about women's health. You just kind of hit one of the hot buttons on the head, which is let's talk about wellness, not sick. That was a big thing. And I keep gravitating to women's health businesses, which is how I met Pamela and Aurora and Emily. Hi, Emily. And right now I keep kind of following the path of things that I enjoy and want to do, and specifically trying to help women with big unmet needs. And currently I'm the co-CEO of a company that has a product in the women's health category, actually for pelvic organ prolapse, which is, you know, a real tough one. So happy to be here.
Fabulous. And last but certainly not least, our male member of the panel, Ryan. Will you introduce yourself to everyone, please?
Of course. Really excited to be here. Really excited to be representing the male perspective in women's health. I'm an innovation associate. My name is Ryan Schumacher. I'm an innovation associate for the Center for Healthcare Innovation at Penn Medicine. And I'm the innovation lead on a program that we developed over the last year and a half called Healing at Home, with a goal of improving the postpartum experience in two ways. One, by implementing prioritized discharge based on clinical safety checks, so actually helping mothers and their baby get out of the hospital when they want to leave, instead of necessarily having to stay for as long as they want. And then bridging the gap in postpartum care during that 6 weeks when they don't necessarily have a visit with an augmented intelligence chatbot that we've called Penny. And it's a clinically validated resource available 24/7. It provides clinical guidance from teams at Penn Medicine. Patients are able to receive automated answers to their questions. And then if they ask something or indicate something that potentially needs care, we're able to escalate that to the correct care team and correct provider to be able to provide the most targeted care possible. So it's really trying to combine clinical expertise, both obstetrics and neonatology, to make the postpartum experience a little better, because I think it can be seriously improved in the United States.
And we do not disagree with you. And thank you for that beautiful setup. Ryan, as Pamela shared, welcome to all of our esteemed panelists. This should be a wonderful conversation. And we're going to start off with our first question for our panelists, which is, you know, how would you articulate, how would you prioritize the key challenges that women specifically are facing as it relates to obtaining the services that they need for their health and well-being.
I can start. I mean, I think that what I have seen over years of practice, and just to give you a little bit of background, I've practiced in every socioeconomic, racially diverse, scenario, right? So my residency was at UT Southwestern in Dallas, and we did, 20,000 deliveries a year, and it was a public hospital. And then I went into private practice in Austin, and then I came out here to do private practice. And it's the biggest problem I see is access to care. And I mean that on a couple of different levels, right? So even if the resources are available, it's how do you get there? Right? How are you a working mom of 3 and make it to every prenatal appointment? How, when you live 30 miles away from the closest doctor or healthcare provider, do you physically get there? And what's been really exciting to see is how telehealth, we had to get there because of the pandemic, but how much patients are enjoying it, and how much more effectively we can actually reach people. And I hope it's here to stay. We love it, and patients love it. So I think it's just the physical access to getting to where you need to be is number one. There are a whole slew of problems, but I think that's the number one problem.
Marianne, I see you wanting to build on that.
I do. I'm really glad that Rathi brought that up, and that we have the relationship we have. In fact, I met Rathi about 1.5 years ago, and because of her passion around increasing access, she was kind enough to agree to join the board for Maternity Care Coalition. But I want to talk about that whole issue of access and how there are barriers to that. What we talk about is the social determinants of health. So Aurora, when you ask that question about what is a big challenge, and Rathi talks about the access, we have to also look at where are those, roadblocks, if you will, to the access. Some of those roadblocks, have to do with poverty or housing, all the things that we classify as the social determinants of health, which are really thread together in this country by systemic racism. And I think we have to really face that. And that is what this pandemic has really shown a very bright light on. But I also think that the digital divide, because we are talking a lot about this telehealth, right? So let's really be clear about, it's not just having a smartphone, it's not just having a tablet, which we're very grateful that many of our clients, we've been able to get them, but we've got to have the broadband. We've got to have equitable access to the capabilities that are being opened up as a result of this telehealth. So that's a big challenge as well.
Thank you, Marianne. Veraj?
Yeah, I also agree that one of the biggest challenges is barriers to access. Inadequate health insurance coverage and the high cost of healthcare, to me, are some of the biggest factors. We know already that many women, almost like more than 1/4 of women, skip their needed medical care because of high out-of-pocket expenses, even if they have insurance. And now with the pre-existing condition mandate and other aspects of the Affordable Care Act in jeopardy of being reversed, women are at risk of losing their coverage for maternity care and birth control. And unfortunately, access depends on whether you have a good job that provides health insurance or can qualify for Medicaid. The other issue is the lack of social support. Many women have to choose between work and family due to unaffordable childcare and inadequate paid leave policies. Many women in the US do not get paid maternity leave, and that forces them to make some tough decisions about whether to go back to work before they're ready, or dropping out of the workforce altogether. So, there are a lot of solutions that we need to look at. One could be, making maternity care and birth control considered preventative care covered by all insurance plans, having adequate insurance coverage regardless of employment status, as well as paid maternity leave and subsidized childcare for those who can't afford it.
Renee or Ryan, I think you want to. Renee, I think you're on mute. You want to add on?
No, can you hear me? I think I'm off mute.
Yes.
Okay.
Yeah.
Look, hitting on some really deep topics, right? Access to care and all kinds of things. I would add a couple of others. Probably, they're just part of the everyday reality. If there's anything positive coming out of COVID, I have to say the exponential growth at telehealth, I think, is pretty exciting. I think it's pretty exciting for women especially. I mean, I happen to work in a category that the topic is kind of embarrassing to talk about. So, I mean, outside of the fact that I think we can be more efficient about how we take care of our families, I think one of the things I've said for years is that women tend to be the CEOs of the family health. So we're not trying to take care of ourselves and also the kids and also our husbands or significants. And, oh, by the way, let's just layer on aging parents. I mean, if I think about if telehealth was back then when I was trying to take care of all of those people, and where it is now, it makes a big difference. So that, I think that's one advantage, and I think it's a priority to make it better and better and better. And I also think that it's another opportunity for topics sometimes in the women's health category that are hard to talk about, that we could potentially be in an environment that we could get on the phone with a trusted nurse practitioner, GYN, and talk about these things, and we'd get better information and probably faster care.
I can offer a couple things that build off a lot of what has already been said. And I think the two things that I would say kind of build off each other. One is, I think we don't necessarily do a good job of meeting mothers where they are. And part of that has been referenced a lot with telehealth and other things by the other panelists here. But I think, we have this system that's built for what we think the healthcare providers think patients need, but we don't actually ask the patients what they actually need and meet them where they are to deliver the care that they really need. One of the it's just an anecdote is we've been trying to build this program for a year and a half, and we've run up against a lot of barriers. I think one of the silver linings of COVID has been that the general acceptance, you've heard it from a lot of people already on this panel who are healthcare providers, but at Penn as well, the general acceptance of digital health tools to really level the playing field a little bit more, and that becoming more mainstream, I think is fantastic. I think there's a lot of things we need to be careful about as we develop these, and making sure that they are developed and administered ethically and fairly across all populations. And then I think the other thing that is systemic is that the incentives with insurance and what patients really want as well, and this goes with not meeting patients where they are often misaligned. We're starting to see more of a transition to value-based contracts, and I think that will really help to drive care that patients want. But oftentimes that these incentives with what physicians are getting paid for and what patients really want are just not aligned.
I'm going to rip off of that a little bit, Ryan, because we can see how wrong that is by how the whole healthcare system broke down with COVID, right? Like, so our job is, okay, you're sick, you need to come into the office, or we get paid based on what we do to you, yep. not how we keep you well, right? And it's been really frustrating. I mean, I think as I have two kids, And I just went through my own, like, I'm like, how do I not know this? Right? Like how, like I do this every day. Like what is everybody else going through? And really have to work on my own physical and mental well-being. And I was like, there's a whole world out there that we're not talking about. And I have several things here, but I'll keep it short. But one is the hardest people to change are doctors, right? To change their patterns of behavior. I mean, and I'm in it, right? But to like say, hey, we're going to get you to use this. It's going to make your life a lot easier. They're like, I've got my way of doing it. And I understand that mentality and I understand where it comes from. But like, I would love to say somebody came to me and said, like, I'm going to make your life a lot easier. Let me show you how. And in that process, I'm going to be able to help your patients, right? We're just going to create a better experience, not only for your patients, but for you. So you can spend more time, you can do more. Cause I think inherently we all want to do more. And I'd love not to log on to like 15 different things to make it happen. Right? Yeah. Like that is, you hand me a new digital tool. I'm like, I've got to get, like, I have 5 usernames and passwords that I have to change every month. And,
and can I just, I like that riff metaphor, but rather what I want to say is all of this digital help, all these digital helps can separate us from the conversation that needs to happen between you, and I don't even want to call it the patient, you and the person coming in, right? Centering the voice of that. So let's not get so caught up in the technology that we lose that human connectedness. And that is why we have women, and Black women specifically, 3 to 4 times the rate of dying from complications, because we're not listening, right? So I would say that as we adopt these wonderful tools, which I absolutely agree with what Ryan's saying about it equalizing things, and let's make sure that we listen to one another, because we've been telling those same stories. You had them, I had my birth experiences, difficult ones, and you talk to your provider and they're like, you don't know what you're talking about. Well, yeah, like it hurts. Like there's a problem here. So I just encourage us to really start to transform, not, the digital space, but the conversations, and really start to check our own biases and why we don't listen to one another. So.
And why don't we receive the training to be able to hear and understand what people's different perspectives and experiences are, right? And I run into that every day. I ran into it, when we were taking care of a large Latina population in Texas, when I was taking care of a large Black population in Louisiana. I'm like, I don't know where you're coming. Like, I don't know. Like, I'm willing to learn. I'm willing to hear you, but nobody's telling me or teaching me. And like that stuff is really, really important. I mean, I would tell you when I came out onto the main line, I was like, whoa, this is a different world. Like I had to learn those patterns and like where people were coming from. And I had to do that on my own, honestly.
That's why representation matters. You need colleagues to tell you about it. Yeah. And to model it. Yeah.
And
all right.
Off really quickly, just to add one thing that Marianne said, I think is Marianne, you're absolutely right. I think digital health solutions without human oversight or human, like the human touch included in that, are going to fall short always, every time. I don't think it's an either or. I don't think it's like we can replace this, the human aspect entirely. But I think one thing, this is, I'd love to hear the other panelists' thoughts on this, but is that if we can hopefully, using digital health solutions, better enable those conversations to be allowed to happen, because we can let the people who are great at what they do, providing that human care, do the human care that they want to do, instead of all of the other stuff, like you said, Robbie, about like you have 5 different platforms you got to sign into and do all these different things, and you don't want to do that. So how can we enable you to do what you actually want to do?
That would be awesome, Ryan.
It would be. And I actually want to touch on, because, you know, I'd love for you to share a little bit more, Marianne, and this may be connected to the next question that we're hoping for you guys to share as panelists. But I think this notion of human-centered design, we can call it a bunch of things, but it really is listening to voices and listening to experiences and listening to perspectives that, let's all be very frank and very candid, are not sitting in 90% of where decisions are being made. I mean, Ryan, I'm going to kind of pick on you a little bit, you know, as a white male here today. It's like when you walk into your work environment, and this was a question I always asked of myself and my peers, who is in the room? And more importantly, who is not in the room? Because when we ask ourselves who is not in the room, then it automatically becomes our responsibility to ensure that that perspective and that voice and that experience is in the co-creation of what we're solving for. And I believe that if there is nothing else that, well, there's many things that I hope most of us take away from COVID, is that it literally took a global pandemic and for all of our behinds to be sitting at home for us to recognize the vast chasm of how we have been creating solutions and services from a one-dimensional perspective.
Yeah.
Can I add to that?
Yeah.
My big aha moment was, so I trained at Parkland Hospital, which is where the textbook for OBGYN comes out of, Williams Obstetrics. And I thought I was and I was very lucky to train there. 2 years ago, I realized, I was like, oh, all of like the women's health gurus are men. And guess what? They're all ex-military. Like every single professor that I had was ex-military male. And I'm like, what? Like, it was just like this moment for me where I was like, that's the problem. That is the problem. Yeah. Like it, we had a wonderful head of ACOG recently, Lisa Ollier, and for the first time ever, I was completely engaged with ACOG. And I think it really is, it's exactly what you're saying. Like, where are the perspectives coming from? And I would like, it's not just me, like it's Marianne, it's our dear friend Joya, it's everybody that's having different experiences of the healthcare system. Like their voices need to be heard, because guess what? They're the ones getting sick. They're the ones dying. They're the ones suffering the repercussions. What are we missing?
So that's a great segue. And I love so many of the things that have been touched upon are things that we've been discussing throughout this series. Before I ask my question, I'm going to quickly jump back to something you were talking about, Roddy, which I thought was really interesting when you were talking about training, because in our panel last week, one of our panelists was talking about the fact that there's an experiment or a pilot being run. I don't remember which med school it was, but they're actually, rather than just doing sort of traditional medical training, they're purposefully including things like humanities and sort of other disciplines that maybe bring a little bit more of a holistic whole person approach to thinking, to sort of see what kind of a more human-centered focus or outcome there might be for physicians who are trained in a little bit different from sort of the classical, highly clinically focused way. So I thought it's interesting when you said that, because I do think that that's something that we hear over and over again, is this notion of, you know, how do we become more centered on people, and not just people who look like, you know, me or look like Ryan, but how do we become focused on, you know, everybody who's coming for medical care, which is obviously everyone in our society, and not just have the solutions being made by a few people. But I want to circle back around, and everybody touched on pieces of this, I think, in your responses. I'm going to go to what I consider to be the dark place, which is statistics, which are not great for women in this country. In a whole host of ways. A couple that, have really jumped out and stuck with Aurora and I over the years. Number one, women in this country are, I think, 3 times more likely than women in any other developed nation to skip needed medical care because of cost. Women in this country are 3 times more likely to die during childbirth than women in any other country. And as Marianne alluded to, for women of color, that statistic is even worse. They're 5 to 6 times more likely to die than white women in this country, not just compared to other countries. And so, when you think about, these statistics, I mean, it's 2020, right? What are, and I want to also jump into the chat because I think our friend Damaris is already kind of maybe thinking about some of the things that you may reflect upon as you answer this, but why does the United States continue to lag so far behind other developed nations, certainly, and even some nations that, are not considered part of the developed world, whatever that even really means anymore? Why do we continue to struggle so much to care about the people who are part of our country? Why do we continue to see these horrible statistics for women and women of color?
I'll talk a little bit about that. I really feel like we brought this up just and touched on it briefly, is the implicit bias within the healthcare system. And also, I want to point out that there is such inadequate screening and care for mental health conditions, which also disproportionately affect women of color. So we need to work on these 2 areas, systemic racism and the undervaluing of mental health care in our system. And one of the ways could be, as Ravi mentioned, maybe some better training for healthcare providers and personnel, especially in colleges and universities as they're undergoing their initial training. But even those that are established in the field, undergoing implicit bias training. Also, making detection, assessment, and treatment of mental health disorders a routine part of obstetrical and preventative care for all women. I think if providers are trained better and feel more confident in taking care of their patients in with cultural competency and with competency in recognizing mental health conditions, we can get really far in trying to make a more equitable solution.
So oh, sorry, go ahead, Marianne.
I was going to build on kind of what Veraj was saying in terms of it's not an either or, it's an and kind of thing. I totally think that the training is necessary to kind of acclimate, if not, reshape the way providers experience, the whole, delivery of services. But let's not be, I don't want to say this naive, but the way that the compensation is done or the reimbursement, it makes it so difficult to deliver the care the way that we want it and we all expect it to be done. So when Pam was giving those statistics that compared the Nordic countries, for example, to the US or European, and it's like, why do we have different health outcomes? Well, let's look at the way that reimbursement is. Let's look at the way that healthcare is structured. It's broken in this country and it costs way too much. And if we were to address that economic component, which is tethered to those other issues that we talked about before, we may start to see better health. We will see better health outcomes. But right now, it just costs too much, and the way where it's structured is broken. So I think that's why you continue to see these results. So Pam, to your question before, I think it's because it's the economics.
Yeah.
So that was number 3 of 3 that I was going to say, Marianne. There are 3 times a physician is willing to change behavior. 1, during training, 2, when they start a new job, and 3, when it affects their pocketbook. Those are the 3. Those are the 3, the major touch points. Like once we start doing something in a certain way and it works for us, it's really hard to change. So training, when you start a new job, and when it affects their pocketbooks. Those are the 3 things that I've come to grips with that change behavior.
I would maybe add a 4th that I've seen occasionally, which is that if we can remove a significant amount of work or help physicians to really prioritize what they want to be doing instead of what they have to be doing, that is one time when I have seen in my projects I would agree that those are probably the main 3. That's like a 4th one. If you can add that on, that's like the cherry of delight on top, where you can actually make their job a little bit better. And I would agree with everything that's been said. I think it's I'm a big fan of aphorisms, and I really like one that I can't say that I came up with this, but I heard another physician say at a conference and said, we're really, in the US, we're really good at sick care, but we're not good at health care. And I think that is incredibly true. And I think, Marianne, as you said, the economics incentivize that. And that's just how the system's been built. And it's all misaligned, and it needs not just like a revamping. It needs a revolution.
Well said. And one last, whoops.
Oh, sorry. I'll jump in a little bit. I think, Marianne, this is to your point. Some really hard conversations need to happen for real, true change. And I'm hopeful that those conversations are going to start to happen. But hope is not a strategy. And I think the other thing that, Ryan, you're bringing up, Ravi, same, the hard conversations, the honest conversations, they have to happen, but compensation is part of it, because the behavior really won't change unless there's a reason to change. And, I'd love to think that everybody's going to do the right thing just because, but I think that if that was the case, maybe we wouldn't be struggling and we wouldn't be looking at statistics like this. So there's more that has to happen. And I mean, to speak maybe to the dark side a little bit, I mean, it's really interesting to hear the conversations and the thoughts from the docs, having grown up in the corporate environment, which might be the evil dark side, but I mean, the conversation needs to change big time there too. Innovation does happen in that environment. And, frankly, I'd like to say that there's been more progress in the last, I'll mumble how old I am, 20, 30 years, that there were more women at the C-suite table, and there's more women engineers sitting there talking about the products that are going to change people's lives, both men and women, that there's more women in clinical trials. We're doing tests on guys, those kinds of things. So all of those hard conversations and the compensation is part of the fix.
And thanks, Renee. I was going to say that community health workers, doulas, midwives, if we could create that bond between the provider, the medical provider, and offer doula options, midwives, because we're talking about women's health here. That is also a way of addressing some of the differences, because in European countries, that is much more an option than it is here in the US. So I throw that out there as well.
And I saw that should be that should be the norm, and not, it should be available to everyone, and it should be covered by their insurance. It shouldn't just be a luxury that some people can afford.
And I think it's also about setting expectations too, right? For I love the doula midwife model, and it took me a long time to get there. Honestly, my practice in Austin, we had midwives, and I think even like I trained with midwives, but there was such a disconnect between physicians and midwives, and I have now learned to value and respect the roles that midwives and doulas have in healthcare, and realize like you don't really need me as an OBGYN to do 70% of what I do. You need me for the 30%. That's what I'm trained for. And so like when we're talking about access to care, like there, right? Like being able to reach like maternity care coalition's done, right? Being able to reach a larger number of people through community health workers is huge.
Thank you. I want to share some stats with everyone because Pamela started off this question by saying women's health. And in that construct, we're talking about white women, we're talking about women of color. And I think that there's a very untapped voice and power that white women have as it relates to this conversation that is woefully not being taken advantage of. The statistics for white women represent $12.1 trillion in spend in the United States. 12.1. That means that they represent 85% of the purchasing power in the United States. The majority of advertising and media that is directed to consumers is predominantly directed to white women. 53 million white women voted in the United States or are eligible to vote. And I'm not going to go through the rest of the statistics just because we all know how the voting block happened in 2016, at least at the national level. So one of the things that I would offer to this conversation about women, and part of what we're exploring is what do those numbers look like for women of color? But one of the biggest, in sharing those statistics, I share that with my white sisters because I believe that there is a voice, there is a moment of account, and a power that you absolutely have quantitatively in this United States. And I think the moment to step up to that accountability and demand changes in a healthcare system that will not only create a model of well-being for you, but my hope is that it creates a model of well-being for all of us. And I think that there is this non-awareness or non-leveraging of that power that exists in demanding change within our healthcare system. As a solution, and I share that because I personally know that women that look like me, we cannot get it done by ourselves.
So I agree. I wouldn't stop there though.
Oh, no.
Because on this one, I would say everybody needs to step up for the things that are wacky in the system, and wacky is a kind word. White women for sure, but has it improved? Are there more and more women, in Congress, in the House? Sure. but the power still tends to sit in the hands of men, right? So it's like everybody needs to be, on that, and it'll move faster. I mean, 100% agree that we should get it going, but it's everybody that needs to get involved. And I think we, eyes wide open on the power structure. I'm very hopeful that some really tough conversations are starting to happen. And I think that's what has to happen. But it's not just, people of color, not just white women, it's all y'all. And especially the power structure.
So Renee, I hear you. I hear you. And how do we, the collective we, invite our male colleagues to give up the power that will be necessary to achieve the type of better outcomes that Pam and Aurora are talking about?
Well, look, I'm no expert on the topic. I don't think it should be framed as giving up power to do the right thing. It's having the hard conversation of doing the right thing. And oh, by the way, it pays to do the right thing, right?
That's true.
What's part of the dialogue that we've heard over the years? The reason you're supposed to have diverse organizations is because it's better for everybody to have broader points of view at the table. Now, whether that's, community-based organizations or hospitals or corporations or classrooms or whatever, if you're all sitting around in a room listening to a bunch of homogeneous points of view, how does anybody learn and grow? And so I guess I look at it as, it doesn't have to be an antagonistic give up of power. It's you need to understand. You need to come to the table and truly listen for a change, maybe, to what's really going on. And then economically, I think, Pamela, I love that you always like to go to statistics. It's like, there's math that supports that doing the right thing is the right thing. And math helps. I mean, if you're talking to left brain, right brain, I mean, the mathematics of this, it can't be there's always emotion that drives. And I think that's a great thing. And I hate to use the word emotion because that just is something people like to put on women. It's passion to do the right thing. But let's do the passion with the math. And that's when I think you'll get more people listening at the table. And I think more people have to listen at the table, of all shapes, sizes, colors, etc.
So here's something I would add before we move to our next question, and I'll add this as one of Aurora's white sisters who she asked for help, because she's right. And although certainly there are those in this society who have more power than me, there are also many who I have more power than, just because of the color of my skin. And so I think for me, how I've chosen to try and exercise that power is, number one, you talked about statistics. I've kind of been trying to go out of my way anytime I'm speaking publicly, anytime I'm in a conversation with friends or colleagues about women's health, to make sure that any statistics or information I have about women of color, I bring it up. I don't assume that other people are looking for that information and focusing on it. And I want to make sure they don't forget about it and just focus on, statistics are bad for women generally. Because while that's certainly true, I think it's my responsibility, because I know it's worse for women of color, to make sure that I share it with other people as often as I can. And then the second thing, which is very much related, is when I find myself in conversations as somebody who is trying to be part of the solution on client teams, seems, with some people on this call. In fact, I try to really ask the question, should we have someone at this conversation who is not a white woman? Do we have an opportunity to bring somebody who looks like Aurora into this conversation to make sure that we are getting perspectives, that it's not just me and people who look like me, because of course I'm a woman, but I haven't had Aurora's experiences. I don't have her point of view or perspective, and it enriches every conversation I have. So I very much want to make sure that when I am in those conversations, I'm always asking the question, hey, should we really be having this meeting without somebody who brings a different perspective and point of view? And so I think it's absolutely, a combination of, using the statistics to get people to hear us, but also recognizing that there is power that I believe I do have, as Aurora said. And I want to pull Aurora forward. I want to pull all women of color forward. I'm ashamed to live in a country that is treating people who I love so much worse than they're treating people like me. And so, having said that, I am going to move to our next question. Aurora, unless there's anything else you wanted to say. Are you good? Okay. So I'm going to move us to our next question, which is actually a follow-up, because I thought it was kind of interesting as we were talking about statistics and as we were talking about, some of the things that are happening in healthcare, and we're talking about compensation, Marianne, talking about how that's one of the big issues, is sort of how our healthcare system is even built. And I'm going to put the hot seat on Roddy and Veraj, because you both are and have been providers. And I'm just really curious, does this get talked about? Do providers sit around and say, wow, we're actually failing women? Our outcomes are not great. If I'm, Elon Musk, I can just look at my stock price, and then, I've got investors saying, why are you screwing up the stock? But, in your world, what's sort of the corollary of that? Does someone come to you and say, wow, things don't look so great? Or is there an awareness of it? Is it talked about? Is there disappointment? I'm just curious, because I think for us as consumers, and certainly those of us who work in the healthcare space, we have feelings about what's happening. But I'm wondering if you're kind of an insider. What is it talked about? How you feel about it? Is there awareness of it? I'd just love to hear any reflections and thoughts that both of you ladies have on that.
So what happens now is that physicians are tracked, right? You're tracked based on whatever your complications are, your admittance rates, whatnot. How many, level of lacerations, readmittance to the hospital. And my viewpoint has changed somewhat, but the metrics by which we are tracked are found to be an annoyance, right? So what they're using as their data points, are literally out of our control, right? They haven't given us anything, I can't change that, right? Stuff happens sometimes, and I get it if I'm having the same complication over and over again, I need to be informed, but the data that I am receiving is not usable, actionable data, right? And so what happens is people change the way they document, they do something a little bit differently. So it's not actually translating to improved health outcomes from my perspective, right? And it's because there's somebody with a spreadsheet in corporate, headquarters somewhere that are these are the things that we need to track. So maybe ask me, right, what I think, and instead of telling me what I'm doing wrong, because none of us want to fail, right? When we don't want to get a bad grade, because it literally comes out as a percentage, right? So you're talking to a bunch of type A doctors, and you're I got 50%. What? How I'm gonna get? How do I get the 99%? But I would tell you that I don't think the awareness is there. I don't think that there's some things that I've tried to institute in my office in preventative care, just telling people what comes up next, or incorporating some physical therapy exercises into just preventative physical therapy exercises. to Viraj's point, talking about doing EPDS screening or finding a better tool than EPDS to do screening. And it is like pulling nails to getting people back to what Ryan was talking about, like to change their behavior, because I don't think that there is a corollary between what I'm doing in the office every day and poor outcomes, which
Right.
it should blow everybody's mind, right? Like it's, so.
And why is that? Like, does that corollary not palatable to you because you don't see it, or you're screened in from it?
Well, I think maybe it is because if you feel like you've checked all the boxes that have been the boxes for over 50 years, you feel like you did everything right, and that was bad luck. Right. So I think the boxes need to change, right? Maybe the boxes need to be, we're screening more for mental health versus syphilis, which is pretty much gone, right? Like we can do both. It's not either or, it's both and. But the boxes that we are taught to check are outdated boxes. Right? So when something bad happens, when something terrible, like, a mom in postpartum depression, we're like, well, we did what we were supposed to do, right? Like, so there's not accountability there. But I think it just goes back into reinventing the system. Like the boxes are new. The checklists are new. Like we've got to start thinking about different things, because it literally is a 50-year-old model that we're working off of, like before moms worked on a regular basis, like, before. So yeah, I think, that's the first time I've ever thought of that, but I think the boxes are wrong.
Got it.
Jenny,
So,
want to add? Oh, sorry, Marianne, go ahead. I'm sorry.
that's all right.
Go ahead.
I just wanted to note that about the 50-year-old or the boxes being old or outdated, and the fact that we were talking earlier about the connection that often doesn't happen, and then pulling in what Ryan said about the wonderful work they're doing at Penn Medicine. And Raj, we talked about this before, if those old methods were eliminated and you were able to really just have a real conversation, like a lot of the administration or whatever the things that you don't need to do were removed, could you not like eliminate those boxes and get that 99 and make sure that the mom or the patient or whatever, the human being is cared for? I think the reinvention, we can use the ideas that Veraj has talked, that Ryan's talked about, and transform this industry into one that really takes care of people. And I think it's going to take all kinds of innovative solutions like we've heard today.
Yeah, I think currently in healthcare, there are a lot of barriers to allowing us to take care of people. And as Ravi pointed out, I'll just give one example of a technology solution that came out several years ago called electronic medical records. And when I see her covering her face, right? I mean, when electronic medical records came out, it came out as like a federal mandate. You must adopt electronic medical records. You must meet all these meaningful use guidelines. Otherwise, you don't get your 99% report card when you get audited. And if you don't, ask this question at every visit, whether it's a necessary question or not, it takes away from the time that the doctor has or the provider has to ask the right questions at the visit and the necessary questions, because they're so worried about making sure they check every box for meaningful use purposes, or for the auditors that are going to come look at their records afterwards and tell them that, hey, you didn't bill correctly or you didn't do this correctly. So, and then on top of that, there's so much that physicians and providers do that don't get reimbursed for. And so they avoid doing those things as much as they want to. That's the person-centric or people-centric way to actually take care of the patient, we avoid doing those things because number one, we're, strapped for time, and number two, we don't get reimbursed for that work.
Right.
And I'm going to add another piece to that, is that I've decided, like, there was a moment last year that came when I was spending more time with my electronic medical records than in patient care. And I told myself when that moment happened, like, I was going to fundamentally change how I did things. So, you know what, my documentation, like, I'm like, meaningful use, like, I don't know what to tell you. Like, there's a lot of copying and pasting, and I make sure I get down what the next person needs to know. Right. Because that's actually what it's about. Like, it's the concept of electronic medical records is fantastic, right? Like, how do we break down the silos that have been created, and the lack of, me knowing what Veraj did at her last appointment because the patient moved, whatever it is. So the idea behind electronic medical records is a beautiful one. The implementation has been a disaster. And I literally spend 1.5 to 2 hours documenting per hour spent with patient. It's moved from 1 to 1. I would say about 1.5 hours in front of a computer.
Wow.
And I'm actually, like, quasi tech savvy, right? Like, I'm pretty good at it. And yeah. And that data is out there.
Yeah.
Ryan.
Yeah, so I was just going to say, I think when the EMR or EHR concept is fascinating. It's a mess. As I don't have to spend as much time in it as the physicians do, but when I try to navigate it to find the data that I need for things, like, good luck to me trying to find what I need. And sometimes it's in 15 different places, all the same thing. So then one thing that I've been thinking about for a couple of years now is, I think newspapers transition decently well over to a digital form. But I think, like, for example, the New York Times, like, it's actually a pretty delightful experience to read the news online. But I think one thing we did with the EHRs is we just took the paper and we put it on a computer. We didn't really think about that translation. And I think that needs a lot of work. Radhi, I have one question for you. I'm kind of like stealing an audience question here, but what are the boxes? This is the designer in me that's really curious about this. As you mentioned this, what are the boxes that you would want to be measured on as we think about, like, co-design and what would you want to be measured on?
So I'm actually really happy to have that conversation more in depth with you, as I've thought about it more. But I would tell you off the top of my head, like, I think it can start from the beginning of women's healthcare, right? Like, when a girl turns 14 or 15, like, what are they thinking about? What are their worries? I can tell you, my daughter, who's 15, her concerns are very different. And what her experiences are very different than what mine were. Right. And I think mental health, to go back to Veraj, is a huge piece of that. Like, how can we address mental health without me sitting there and asking each question, right? Because, like, is that a great use of my time? How can we address preventative health measures? And that's where technology is beautiful, right? Like, when you scroll through and then I receive the data, but I don't necessarily have to ask you those questions. And actually, when you're doing it in private, there might be a more truthful answer than when I'm rushed and asking you.
I was
right?
just going to say that.
Yeah. So preventative health, mental health are the things that come to top of mind. But I'm literally sitting there going, okay, do you smoke? Do you drink? Do you, like, that's the 10 to 15 minutes I have, I'm asking a lot of those questions. And if I just had, like, yeah, I'm drinking a 6-pack every night, I'm like, I can address that, right? Like, we can have that conversation, but that's where technology should be helping me.
Before There's some great questions in the chat, and we're going to jump to those in just a second. Before we do that, I'd love to just ask each of you, and this will kind of a little bit actually touch on one of the questions in the box, but maybe each of you in turn could share something that you are currently working on that you actually feel is maybe, you know, giving you some hope that we're moving in a positive direction, something that might be a little bit out of the box or innovative, or that you feel is taking, you know, positive steps towards better outcomes for women. And obviously something you're comfortable sharing, maybe things you're working on that aren't ready for public consumption yet. But I'd love if each of you could just reflect on something that you're seeing that you feel is actually going to have a positive impact on the community of women that you serve.
I'm happy.
Share about healing at home. I already talked a little bit about it, but just really quickly and this has been brought up a few times, is I think a lot of the technology tools out there are apps or relying on internet and other things. And one thing we've tried to do with this, and I think we've seen a really high uptake, is we're just using text. It's just SMS text messages, and other platforms have done this, but I think it's the easiest and lowest barrier to entry, because most people or many people have that ability to communicate in that way, and it's easy and low barrier. And I think we scared a lot of people when we initially started doing this about a year ago, when we proposed using augmented intelligence for this. But I think now we're starting to see some acceptance of it, and being able to do things like a remote EPDS screening through this platform, through text. And then those results, if they're high results, they get immediately triaged to a physician who can then do something with it instead of doing it themselves. And trying to remove work from the physician, make it a more delightful experience for the mother. You know, we're starting small with this, just in a pilot at one hospital at Penn, and starting to spread from there. But I'm really hopeful that this can be something that can help all mothers truly, and really trying to be deliberate about the design of that to help all mothers.
Great. Marianne, I know you had something to say.
Yeah, I was going to actually build on a program that is being done in collaboration with Penn Medicine, and it is around our Safe Start program, which incorporates having the mom centered and having support from a mental health standpoint, from a community health worker standpoint, from a physician, and by centering the mom and providing that kind of, she's the hub, and we are actually providing from like a 360-degree amount of support. That I think has been very successful, and it has demonstrated positive outcomes. But I also want to say there's another program. I think Penn Medicine is a leader in innovation, and it hasn't yet. It's not ready for public consumption. And Ryan, I don't know if you're aware of it, but it could be. It's going to be introducing some kind of like a belt that will monitor high-risk moms remotely. And we are hopeful that we will be able to get an NIH grant in collaboration with the Penn Medicine and other groups to see if we can get that deployed. I think that'll be transformational. So those are two things that I would share.
Fabulous. Renee, Veraj, one of you have something you want to?
Sure. So at MOL, where I'm working, again, one of the reasons I actually left practicing medicine was partly because of this frustration of providers not necessarily having a seat at the table when it comes to technology and innovation. So I am helping to also work in a pilot. We have developed 3 products that are working in conjunction with each other, which we are also hoping will help take the burden off of healthcare providers on the front lines in women's health. One, similarly using text messaging technology to provide anticipatory guidance throughout pregnancy and the postpartum period to women during that motherhood transition. As well as screening for an EPDS right at the fingertips that can be done in the doctor's office or at home. and then escalating those patients to whatever needed support. And two of the top areas of support that moms typically need are when it comes to mental health and lactation support. So those are two areas where we have started to pilot a telehealth platform with lactation consultants and mental health therapists that we can then funnel those patients directly to. And then the last being resources. Women are constantly scouring the internet for resources that are curated and that are evidence-based. And doctors want to be able to take the time to give them all of these resources and tend to have to hand out lots of packets and papers. And what we're trying to do is put all of those resources that the physicians or providers or midwives would otherwise want their patients to have all online and easy at their fingertips.
Great. Renee?
Yeah, so there's so many themes that have come up, and these kind of fit into the category for me over the years of things that I would love to see changed. And so I'll just give you some examples, because I mentioned in the beginning the company that I'm currently working with. We have an approved medical device for women to treat pelvic organ prolapse. And without, grossing out the guys on the call and going into a lot of detail, it is a condition that in some form or fashion affects 50% of women over the age of 50. So just think about that a minute, because, from my side, thinking about this, I have been very frustrated to see corporations really stepping away from women's health innovation in all categories, but especially in this category of the older ladies. We've talked a lot about the younger ladies. I'm going to talk about the older ladies. So this company has a product that is meshless, that's minimally invasive, and it's approved by the FDA. The only thing standing in our way is raising capital to get it out into the marketplace. We even have doctors lining up that want to use it because they've started to see it. I would contend that any product that would treat or help men if a condition that 50% of them are affected by, we wouldn't have any trouble raising capital. But in the women's health space, raising capital is a little bit more difficult. We're going to get it done. This product will come to market. It will be there for the ladies on the Zoom if you ever need it. But the additional vision that I have for this, and you started to hit on this information. Veraj, I have to know more about your company. I mean, I go insane at the bad information that's out there. Like, just flat out snake oil, wrong information. And in this category that I'm working on, oh my gosh, it's really bad. And it's embarrassing to talk about. So it's hard to get really good information because you're not even necessarily comfortable bringing it up to your doctor sometimes, right? And so, I kind of have this vision when all of this comes together, that there's a company out there, a women's healthcare company, that looks at the whole woman, not just a product, a condition, not a patient, a whole woman, and talks to her, has these deep dialogues like you're talking about, Marianne, where you really dig in on what her situation is, because surgery is not always the answer. Pills are not always the answer. Like, what is going on? And have those dialogues, and then have great information, and then make a decision as a team. And then what is the right answer one year may not be the right answer the next year, but it's an ongoing dialogue. So that's sort of I'd like to try to prove that principle out in my small little company, but the concept applies, kind of across the board, and brings in a lot of the themes that came up today.
Do I get to answer?
Yeah.
I am fortunate enough to be involved in great organizations like Maternity Care Coalition and MOL. And I started Hatch Motherhood, which is where I actually did all my learning, right? Like, you know, Renee, now what you say just seems so common sense to me, but it wasn't 10 years ago, by the way, right? Like, it just seems like, yeah, of course that's the way it's supposed to be. Like, we should be addressing the whole woman. I mean, totally on board, but it took a lot of learning for me to get there. And so currently I am focusing on being really awesome at my job, which is women's healthcare, and implementing a lot of things that I have learned and kicking ass along the way and leading by example. So that's what I'm working on right now.
Yes. So I'm going to segue us into the last question, which was brought to us by Brittany on in the chat box. And this is actually a conversation that Pamela and I have all the time. So Brittany is speaking to us about how in other industries, digital tools, digital technology is leveraged with a high user experience expectation. And somehow that high user experience expectation has been at the expense of our privacy and our data. When you look at healthcare, it's actually very difficult to find a frictionless user experience, specifically when we're talking about EMRs and any type of medical software. And I know that a lot of the times the excuse that I have heard is, well, it's regulatory and it's HIPAA and privacy. And
don't forget legacy systems. It's all the
yes, legacy systems. So, I think the question is, why is there such a discrepancy for our friends in the healthcare? Like, why do you believe that there's such a discrepancy? And will anything change post-COVID?
I don't know. I mean, it's like the whole thing is torture. My office system doesn't talk to my hospital system, and the hospital system's too expensive to get into the office system. So I am faxing. Does anyone remember what a fax was? Like, I am faxing stuff from my office to the labor floor because it's the only thing that's HIPAA compliant. And then on top of it all, like, I'm clicking all these boxes that make absolutely no sense to me. And I mean, I wish somebody would just, the VA back in the early 90s had a beautiful system, and doctors didn't mind using that system because that system was used to talk about patients. And so we'd sit there and we'd type and we'd like talk, like it was a means of communications across the VA to improve their patient outcomes. It worked, right? So I think we need a system that's built for the user. I think we need a system that's built for the human, the patient. And like, you guys can figure out all the billing stuff, and I'm happy to do what I need to do. But like, we have so much technology out there. Why can't I document and you guys spit out a code, right? Like right now I'm a scribe, I'm a coder, and now I get all these emails, like, like I don't know what, like it's just like one thing on top of another on top of another. And I don't sit at a desk and answer emails, right? Like, I am actively doing stuff. So, I mean, I really hope it gets better because it is probably the number one reason as Veraj stopped practicing medicine. Like, I think this had something to do with it. Like, it'll shorten my span of practicing medicine. And I mean, because I'm not doing what I signed up to do. Like, I am like, you guys should just let me do what I'm really good at doing. And if somebody wants to follow me around and write it all down, like, that's great. But like, I'm really good at connecting with people. I'm really good at taking care of people. I'm really good at, like, I enjoy it. Like, I have always loved my job. I don't think you've ever heard me like, I am really good at it. But like, at the end of the day, when I'm supposed to be with my family, I'm spending hours every night. And like, half the time I just don't do it because I like, whatever. But that's not good, right? Because it's our method of communication. I've taken on a lot of stuff, so I'm not taking on fixing electronic medical records. I just gave up that one as Ryan's job.
And Ryan, I'd actually love to hear your thoughts on this because you do work in the design innovation space. I'd love to hear your thoughts on this question. You know, why are things like EMR interfaces, you know, sort of back in the dark ages, and yet, you know, I could order a pair of shoes and, you know, they'll be here tomorrow, and I could actually probably do it while I'm on screen because it's so easy, right?
I think I have a few thoughts around this. I don't have a silver bullet answer, or like if I did, I would totally be working on this. I think one of the reasons is, and this has been brought up multiple times, but I think there's this mentality of like, we need to design it for the doctors. Well, why aren't we designing it with the doctors? And I think it goes in multiple areas in healthcare. Is we don't co-design. We feel like we have to design this for people and do this, but why aren't we just designing it with the people, making sure that those people are represented at the table and their opinions are captured, not trying to guess at them, but actually like understanding what their needs are and meeting those. And the EHRs that have been built, at one point in time, they were probably really effective. But as medicine has changed and things have changed, instead of scrapping it and saying like, hey, let's rethink this entirely, we've just built additional modules and plugged them in here and there, and we have this Frankenstein creation that is just not very effective, and definitely like the least delightful thing. And so yeah, I don't know what the solution is. And I think one of the reasons why it's probably hasn't been addressed is, well, that said, is like, Brittany, to your question, is Google and Apple are starting to play around in this space a little bit. And companies like Epic are starting to get worried because a company like that who thinks innovatively and creatively about it and isn't stuck in these legacy systems could totally upend the whole game. But I think it's mostly dominated by a few companies. Epic and Cerner are the two big companies that pretty much all the big hospitals use. And there are some other little smaller companies out there trying to do things, but I think there needs to be, like, ideally there would be this company with a bunch of physician coders who would be able to take a stab at this and get the funding necessary to like really upend this system. And I think it is absolutely ripe for innovation, and it just needs to be the right team who attacks it and is willing to dive into the muck and figure it out.
Britt, I think you kind of, I was looking at the chat, you kind of answered the question. I mean, this needs to come out of the hands of sort of the status quo. The status quo has completely blown this. They didn't listen. Everything's wonky. You know, Epic and Cerner own it. The hospitals hate both systems. And they basically keep trying to put bubble gum and duct tape on an old system as opposed to starting over completely fresh. And it really probably should be a room full of doctors with the tech gurus, and anybody that's in the C-suite shouldn't even be allowed in the room. And you know, there can be no hierarchy in there, but it's like it has to start over and completely fresh, because I just think that we got to where we got by putting bubble gum and duct tape on the old system. And then people, I think, Pamela, you reference this, and I think people, and I've heard this, I've been in meetings where I've heard this, that people stood behind an excuse of regulation and we can't do this and da 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 da. I mean, that's kind of, none of that was helpful. It's going to have to get blown up and put back together in a different way. And I like your idea, Brittany.
I would offer one other thing too, which Aurora and I have seen quite a bit in the work that we do, which is that I think healthcare tends to have a checklist mentality. And so it's like, oh, great, check, we created EHR. Now we don't have to worry about that anymore. The reason why companies like Google and Twitter and Facebook have been successful is because they continue to iterate on their product. It's never finished. Every week they're adding new features. Every week they are reaching out to their users and trying to understand what's working and what's not, what's missing and what's great. And so they're constantly iterating on this product, and they see innovation as a process, not something that is sort of finished. And I think that's another sort of mentality shift that the healthcare industry needs to do as well, where it says, great, somebody helped us create a better, because I agree with you, Renee, and this isn't a but, this is a yes and. It's like, let's create something better from scratch, but then let's not ever think it's finished. Let's continue to challenge ourselves to say, are we continuing, as medicine evolves, are we continuing to meet the needs of the consumer and user who's relying on this tool? And if we're not, how can we make it better?
If you really want to change, so on that same note of constantly innovating, if you really want to change women's healthcare outcomes, you get the American College of Obstetrics and Gynecology involved in updating EHR information real time, right? And so when recommendations change, the hardest part from our colleges are like, we have the research, we have the data, but how do we implement those? Not amongst like academics, private practice, rural medicine. Well, you can do that through your EHR system, right? Like if it is a constant update, like I have a patient that has gestational hypertension, high blood pressure, and pregnancy. These are the new recommendations. Well, they automatically populate, and like it's taking out of my headspace. Like I remember what those things are, but I can't remember like all the details. And maybe I didn't read the most recent clinical paper because I'm saving that for, September, October, November, like, cause it's due, so like, why aren't we like, it's the technology has to be there, but it's really like, this is my day. I'm having to remember that somebody has hypertension, and then I have to put in the right orders. And then not only do I have to put in the right orders, I have to click a box each time to put in each order. And that order has to match a code. So the insurance company pays for it. And like, that's what my day spent doing. But if it automatically populated, these are the top 3, evidence-based treatments for blah, and I could check what I wanted, like, why can't we do that?
So I've always believed that, and I put this in the chat box, I think, the reality is that we took a back-end system that was never intended to be a front-end system to foster, support, connect the conversation, the interaction between a physician and a provider, and we made it that. And we bug-gummed it, we duct taped it, we did all this stuff, and it's a Frankenstein, as you well said, Ryan and Renee. And if I were Epic and Cerner, I would be sitting there having a completely different organization with all the money that they've made. I would have a completely separate team literally sorting out the next evolution of that platform if they hope to be in the game long term. Because I think, to your point, Brittany, my hope and my prayer and my guess is that there are technology leaders out there that see the opportunity, economic, first and foremost, opportunity that exists in health. And I think they're going after it. And let's hope that they do. So I think that we have reached our time together. Is that correct, Pamela?
Yeah.
So huge, tremendous gratitude and heartfelt thanks to each and every one of our panelists, to all of you that took time out of your busy days to join us to have this fruitful conversation. Please follow these thought leaders. They are making a difference in our world. They are making a difference in women's health. And please stay connected. And this culminates our 3-part series on health and human connectedness. And for those of you who have been on this 3-week journey with us, we also thank you. So with that, we bid everyone a wonderful afternoon, and please stay in touch. Thank you.
Thank you all so much.
Thank you.
Thank you.